Alan Percy. I'm a pediatric neurologist at the University of Alabama at Birmingham and work here at the Children's Hospital of Alabama. I've been here since 1992. I saw my first patient with Rett syndrome in 1983 and have been following these girls since that time. Have been involved in both a natural history study, which ran from 2006 to 2021, and we have been involved in a number of clinical trials, including the trials with trofinetide, or debut as it's called. Trofinetide is a small molecule. It's actually the terminal tripeptide of insulin-like growth factor. It has been modified chemically to make it available as an oral agent. So it is just the terminal tripeptide, which is the active ingredient. This does not act on the receptor in the brain for the basic compound, but does act at a number of developmental sites which regulate the biochemistry or the neurochemistry within the brain. So the DAFFODIL study was a follow-on study to the so-called Lavender trial, which was the basic phase 3 trial for trofinetide in girls or women 5 to 20 years of age. 187 individuals were involved in this trial, roughly divided to treatment and placebo controls for a period of 12 weeks. And the Lavender trial was then continued through the full year. It's an open label trial, so all of the individuals received the medication after that point. The Lavender trial showed that trofinetide was quite effective in improving interaction, communication, in some regards, improved hand function and gait in those individuals who were able to walk. One of the principal findings from the natural history study was the top concerns of parents. And the number one concern that parents had, and this was in 25% of the individuals, was that of communication, the inability to know what their daughter wanted or what she was trying to say. And so the improvement in communication was regarded as a quite important and impressive result of this medication. It is important to recognize that trofinetide is by no means a cure, but it does provide some incremental improvement that allows the interaction between the girl and her family, parents, or caregiver to do much better than without the medication. The other top 5 concerns included hand function, ability to walk, or gross motor function, and the last one was constipation. Now, one of the principal side effects of trofinetide is a loosening of the stool. So in effect, that was an improvement in one regard. It was a negative in another regard because sometimes the diarrhea was quite significant. Diarrhea was not seen in all, and we have had a number of girls we've had to put back on Miralax or other stool-producing agents because of the continued problems with constipation in these girls with Rett syndrome. What we have seen is a better interaction, more direct responses, in some cases single words, or in other cases full sentences. We have a young woman here who was admittedly higher functioning. She had Rett syndrome, but was higher functioning and had the ability to say some words, but they tended not to make any sense. They weren't really put together in a communication format. But with the trofinetide, she's now speaking in 2 or 4 word sentences and making very good communication sense. The other aspects of motor behavior, I think, are quite interesting, but are not consistently seen in all girls. This particular woman that I mentioned, a young woman, is able to use her hands much better and ambulates much more purposefully, but admittedly, was at the higher end of the spectrum to begin with. What we have seen is that when we initiated the trial in lavender, we didn't have a very defined program for dealing with the diarrhea. Over the course of the study and the subsequent lilac studies, we did develop a mechanism for dealing with the diarrhea, either in the form of increased fiber in the diet or anti-diarrheal medication. And we have a clear program now to implement that. In addition, what we have done, of course, during the trial, you had to start with a certain dose and continue that through the trial. In the open label portion now, what we do is we tend to start at 50% of the weight-based dose. So let's say an individual is supposed to take 40 cc's, 40 milliliters twice a day. We'll start at 20 milliliters and go up by 5 milliliters or perhaps 10 milliliters every week or every other week. That gives an easier way to deal with the onset of the diarrhea, that when it does occur, and we can either pause the increase at that point in time or even back off for a week or so before increasing again. At the same time, implementing the anti-diarrheal preparations, either the fiber or the Motrin for the diarrhea. Well, in the DAFFODIL study, which involved girls 2 through 4 years of age, there were only probably 12 who completed the study. So it was a much smaller study, and it was open label, so all individuals received the medication. And my personal opinion is that if you're going to treat a disorder, which is gene-based, it's probably better to treat earlier or younger than later. You may see better effects. And I think we tended to see that all of these girls seemed to do much better than in the lavender trial. And there was an interview with about half of the parents or caregivers of the children involved in this study, and they were quite pleased by the results that they have seen. And at least in our site, we did not see as significant diarrhea. And one other point, vomiting can be an increasing effect in individuals on trofinetide. And in our study, we have always been aggressive in treating gastroesophageal reflux with proton pump inhibitors, so that at our site, we really did not see a major problem with the vomiting as was seen in other sites. I think probably the principal message going forward is that you don't have to start at the full dose. You can start at a lower dose, gradually increase it to the point of either full dose or maximum tolerability. And we are quite pleased with the results that we have seen in that regard.